decision shapes recovery. All Things Neuro and Neuro 360 is a specialized neurocare organization focused on the diagnosis, treatment, and rehabilitation of traumatic brain injuries and concussions. A multidisciplinary team works together to deliver coordinated care, guided by advanced diagnostics. All Things Neuro and Neuro 360.
All right, guys. So we're talking about making the invisible visible. And essentially, it's how do we really detect things that, unlike a broken arm or, a skull fracture or the majority of physical injuries that are, very visible, how do we detect things that are less visible? And really, what do we do with that? And so I've done personal injury, medical legal work for about 20 years. My wife's a lawyer, so I literally live with this stuff. And I feel like there's generally these four major questions. One, is there an injury? Two, how severe it is? Three, what caused it? And what are current and future care needs? That's fundamentally the questions that I have to answer or that a lawyer needs to pull together in order to make a solid argument. Now, my experience is it's better when you really paint a picture of what's happening with people, how it affects them, that there's a story that helps a jury understand these things. But these are generally the four questions I think that need to be answered. So how do we test for cognitive injury? We could do imaging. You could do an MRI, which for mild TBI will not show injury unless there's a skull fracture. Diffuse tensor imaging, which looks at white matter tracts, the wires of the brain, and particularly looking at structural abnormalities consistent with TBI. To be clear, in mild TBI, by definition, MRI is negative. So, hopefully everyone on this lecture realizes that just because an MRI doesn't show anything certainly doesn't mean that there's nothing going on. And frankly, similarly with DTI. Now, you can do something like a SPECT that looks at glucose metabolism and some other things, but again, just because they don't show anything doesn't mean there's nothing happening. It means that the technology of the imaging isn't sophisticated enough to detect these injuries. Sometimes you'll do an EEG, you're looking at abnormal brain waves. In particular, you're looking at has the brain signal changed? Is there slowing in certain areas? Is the person having seizures? Sometimes people will use QEEG to try to explain kind of what's going on. My experience with QEEG is certainly it can be added data, but in absolutely no way is diagnostic. You can also do a visual ocular exam, and that looks at basically how the eyes center around a particular focal point. And the pattern of focus is indicative of whether or not there's abnormalities related to the visual vestibular ocular system. And that lets us know, is this consistent with TBI or is it not? You can also do a neuropsychological assessment. I am trained on EEG, I'm also trained in biofeedback and a bunch of other things. And certainly I order DTIs and things like that. But I can tell you that for me, of course, I'm a neuropsychologist, but I get more information out of the neuropsych assessment than I do anything else. And what it answers is, how is the brain functioning? Are there legitimate functional changes? Are these changes consistent with a particular cause? One of the things I'm going to highlight moving forward is that there's a lot of screenings that people do, brief cognitive assessments, computerized only assessments, and those are fine only as screening. They are absolutely not a replacement for a full assessment. Well, why not? Because a neuropsych assessment involves several major parts, which we'll highlight in a minute, but truly it's looking at medical history. Does that line up with patient report and collateral? Does that line up with what you see? This piece is important. Neuropsychological assessment will spend roughly 4 hours with a patient. We are looking at, does their presentation, which includes a full neurobehavioral exam, sometimes a cranial nerve exam, I'll do a full motor exam, does that line up with what's going on, right? You don't get that from a brief screening. I mean, an impact would be great to screen someone, right? There's lots of these CNS vital signs. There's lots of these things out there that screen, but they don't tell you what's causing it, and they're not matching that up with what you actually observed because the patient's just there on the computer, right? And even if they were, it's short, it's a half hour. And that doesn't let you know, well, what's somebody going to be like if they're working? They have to sit there all day. They have to sit there multiple hours. And what you find over a longer evaluation is when people start to decompensate. What is their cognitive fatigue? When does their attention break down? And ultimately, for a trained neuropsychologist, they can tell you, are these changes consistent with a particular cause? That's important because you don't get that from any type of screening. All you'll know is there an abnormality or is there not? But I can tell you if it's due to sleep. I can tell you if it's due to pain meds. An example that I'll highlight as we go through this is I had a case 3 days ago, and I was talking with the lawyer about it, and this person had a stroke, and that stroke was 16 years ago. It was significant, and basically it was a frontal lobe stroke, which most strokes are in the middle cerebral artery. This was anterior cerebral artery, and so it's really affecting that frontal area. And they had to relearn to talk and do all these things. Right. So what I need to determine is, well, what's due to stroke, and what's due to this accident, and then two, the main argument from the opposing side in this case, from the defense, is there was three people in the car, two are perfectly fine, one's in terrible shape. Help us explain that. Help us explain that. That makes no sense to us. It makes total sense to me. The person had a stroke. They were clearly neurologically compromised to begin with, and so it took far less for the bottom to really drop out. Now, all of a sudden, an aspect of the case that the side that hired me that was concerned about, like how do we make sense of this stroke, becomes a strength. It helps explain exactly what happened, right? And those are things that are really hard to determine through any other type of assessment. Now, for personal injury, you have two main categories where a neuropsych assessment is particularly helpful, right? And certainly you can do a PTSD eval and things like that. All neuropsych assessments look at everything psychiatric and psychological and everything neurological. It doesn't do both. That's why it's neuropsychology. They are fully comprehensive. So a neuropsych can replace doing either separately. But you really are focused on assessing TBI and pain. And I'll talk about pain in just a minute and how like a pain process or a pain IME can be helpful. So what does neuropsychology do? Is there evidence of relative kind of weakness? Relatives in bold, as you guys can see. Why? Because we can compare someone against themselves. Right now, I have at least two lawyers whose cases I'm on, and the patients are lawyers. I have a physician that I tested, it's been about a week ago. He's an ER doc. So testing is going to come out as average, right? Someone could say he's average. Dr. Hurt says he's fine, he's average. You do not want an average ER doc. I promise you do not, right? And so we are able to determine their pre-morbid intellect within 5 points of IQ. It's so accurate that even in mild to moderate Alzheimer's, you could tell within 5 IQ points who they were before any changes. It's unbelievably accurate. So you're comparing people against themselves and thousands of people the same age, the same education, the same gender, the same ethnicity. So you're comparing people against people like them. And you could determine what caused it. Is it due to brain injury? Is it pain? For sleep, we can see variable processing, reduced attention, vascular issues. Let's say you have somebody who has hypertension, diabetes, hypothyroidism. Their B vitamins could be low. That directly affects short-term memory. They could be anemic. That affects processing and attention. They could be on gabapentin like half the planet, right? And that causes slow processing, variable attention. So you have to make sense of this. And someone will argue, well, all this is due to meds. This is due to the fact they had, their thyroid wasn't right. I can explain all that. I can get clarity in all that. And to be real, there are certain types of people that are more likely to have injuries. Someone with ADHD who's impulsive and doesn't focus well is more likely to get in a car accident than someone that doesn't have it. It's just facts. So then you have to tease that apart. Pain causes or impacts cognition in lots of ways. The medications that are required to manage pain impact cognition in lots of ways, and it's lasting. It's lasting. All of this comes from the brain, right? Pain is processed in the brain. So when you have acute and chronic pain, particularly if it's chronic and it's lasting, it actually rewires the brain. It changes how the chemistry works. All psychiatric conditions are neurological. All of it. All psychology is truly neuropsychology because there are direct neuroanatomical underpinnings to each of these things. For example, in schizophrenia, The hippocampus that has to do with forming new memories is smaller. The ventricles are larger. In obsessive compulsive disorder, there's changes in the wiring of the orbital frontal cortex that's right over here. It kind of sits over, right? Bipolar disorder tends to be dorsolateral, dorsal fin lateral. So in this areas of the head right over here. ADHD, right, shows that the front part of the brain is smaller and has less connections, and the uptake of glucose is different. All psychiatric conditions are neurological. Even PTSD actually is a disruption of circuits between the frontal lobe, the hypothalamic pituitary adrenal axis, and the amygdala. It doesn't matter that you know what those are, but it does matter that you understand that PTSD is brain damage, And that is why the memories will just pop out of nowhere. It is why sleep is disrupted. It's why it's a lifelong condition. Now, pain also impacts thinking, as we talked about. In traumatic brain injury, it depends on location. But typically in mild TBI, attention and processing speed. Those are the most likely areas to be impacted. So what can neuropsychology do? We can understand symptom severity. So listen, it's one thing to determine if somebody had an injury, right? It's another thing to determine how severe it is and in what way. It's another thing to determine how that impacts their life. And it's another thing to determine how does that impact their future, their ability to work, and to figure out what type of life care plan they need. What are the care that they're going to need for the rest of their life, right? And we determine all those things. We can clarify a functional impact. One of my jobs is I'm an internal neuropsychologist for Davies Life of Health and Lloyd's of London. So that means I am literally working on the insurance side, reviewing lots of medical records, right? And I'm not assessing the patients, I'm reviewing those records, and I'm providing them an expert opinion as what's real and what's not. And I'm matching that up with very specific policies and riders, and I'm guiding the insurance on these things. I have an NHL player I'm working with now. I had a race car driver a couple months ago that I was working with, right? And these cases are worth $1 million a month, right? That's what these things are worth. They're absolutely insane. And the payout might be $50 million. So and there's riders that'll say if this is due to mental health, it pays nothing. If it's due to neuro, it pays millions. And we have to understand what's real for people to make these decisions. And we need to understand how it impacts not just the future, their ability to do their current job or any job, right? So neuropsychology in one assessment answers all 4 questions. What is it? How severe it is? How does this impact them? What does it mean for their future? In one thing. And neuropsychology can detect 100% of TBIs. Think about that. They don't miss any, right? 100% we could detect. Now, figuring out what's due to what, that ultimately comes to the talent of the provider, the level of training they have and their expertise. But it can detect all these things. Now, I understand that not all cases, not all clients really need this full giant evaluation, right? And there are some lawyers that I work with that, what they want me to do is help them understand what cases are real and not. It's fine. I review a bunch of records. I provide them a verbal opinion. I'm not writing a giant IME report. I'm giving them a verbal opinion. Yeah, man, I think this thing is real. This is the exact reasons why. This one's solid. Right? This one, I think this person's really struggling. And either I personally can work that case up or somebody else can. But I'm happy to give guidance and advice as to what is actually happening, just like I do for the insurance companies on an every single day basis. Now, additional support is gained from your MRI, DTIs, vestibular ocular exams, EMGs for pain. So when you're building a case as a lawyer, and again, my wife is a lawyer, so I hear this every single day. She watches court TV, I think most of the day. So I get between clients, right? And so I get constant things about this medical expert was absolutely terrible. Jeremy, you should never do this ever, and so I'm getting coached from the inside. But ultimately, you're building a case. And you're doing that by providing data points that overlap together to really paint a picture to help understand what's going on. And if you add all these things together, you end up with something that's very, very, very difficult to defend against because these data points are converging to paint a picture. Let's talk a little bit about pain. Now, a neuropsychology pain IME helps understand the impact of pain medications on cognition and mood. So it is clear, specific data that shows these things, right? Concrete data with numbers. And that could be T-scores, that could be scaled scores. We'll talk about that in a minute, percentiles, but there's data, real data. And it can tell you how the symptoms impact day-to-day function. How will these symptoms impact gainful employment? How will symptoms impact the future? It directly leads to the life care plan. And in pain, which again, I'm certified in biofeedback. I've done pain forever. And I'm chief of mental health at Doctors Hospital of Augusta. That is the largest wound care and burn center in the country. And I'm in charge of the brain injury unit, but also I do trauma, ER, everything. It's where I was this morning. As I'm sorry I'm late for this for us getting started. So we can determine not just the physical needs, right, related to pain, but do they need psychotherapy? Do they need psychiatry? Is it lifelong? What's it going to look like? And if they have to be on a medication, which almost all do, that affects your thinking specifically, then they're going to need some type of neuro treatment for their thinking to help them function at their best. And they will need to be monitored for neurobehavioral care because what do we know about pain? It impacts the brain, as we talked about, which impacts your systems. So adding like a neuropsych pain IME to a non-TBI patient really helps lawyers be able to capture the finances that are needed to support your clients, right? And their lifelong needs and care. If you're just focused on the physical, you're missing 2/3 of the things that they're going to suffer from and that they're going to need help with. So, what is the benefit of a pain neuropsych IME? There's no TBI. Are you serious? Why do I need this? Because it proves cognitive and emotional impact and it maximizes recovery of the finances needed to support long-term symptoms and limitations and provides data that is defensible. Now, neuropsychology as a field combines neurology, psychiatry, and psychology. Now, we are not MDs. I'm not an MD, right? I'm a PsyD, but you can be a PhD or a PsyD. And the difference is a PhD has a couple more classes in research. A PsyD has a couple more classes in clinical care. So if you want to be an academic and you want to do all this research, you generally go PhD. If you want to be more clinician, you go PsyD. Frankly, I do lots of research. I'm currently the lead researcher on the Vegas shooting, trying to understand the impact of mass shootings on PTSD. So like I do research anyway. But anyway, that's the difference. There are 3 major board certifications. ABN, it's me. I'm actually on the board of directors for ABN. I currently have been nominated for president. ABPPCN, which is through the American Psychological Association, and ABCN, which is for pediatrics only. Myself, I'm a lifespan provider. And they're psychologists with additional training in neuropathology and neuroanatomy. And they're focused on evaluating relationships between behaviors and brain function. It is an applied science that's concerned with the manifestation of cognitive and behavioral phenomenon secondary to brain issues. So again, not an MD. Now, you think about earlier in this conversation, we talked about the time that you need to spend with someone to really understand what's happening. Neurologist, 15 minutes, maybe 60 minutes. Psychiatrist, 30 minutes, maybe a couple hours. If you get a really good psychiatrist that actually likes to do therapy, I've met like 3 or 4 in my life. And we're spending 4 to 8 hours with somebody working through these things. And our report writing time is another 3 to 12 because for us, we are integrating the entire medical record. We are pulling things together and we're using standardized procedures and normative data banks for comparative analysis. Now, when you look at neuropsychology versus psychiatry, neuropsychology is really focused on different pathologies and how those relate to emotions and brain and cognition. And psychiatry is really management of psychiatric conditions. So we can answer, like, what in my case is real? Some states really focus on, particularly workers' comp, like South Carolina focuses on catastrophic versus non-catastrophic with drastic differences on limits in cases. And so a question I'm always asked is my case catastrophic and can you prove it? Because now I went from making $10,000 to, this could be a multi-million-dollar case, right? And we can determine that. It can tell you the extension nature of cognitive impairment and psychological symptoms. Again, neuropsych always does both, always does the mental health and the neuro combined. It can also detect for symptom exaggeration. Now your job as a lawyer, or if there's chiropractors or other clinicians on the call, my job as a doctor, right? We want to believe our clients, our patients. We want to believe them. But if we're really being honest with ourselves, really being honest with ourselves, the research supports that 80% of people exaggerate at least a little bit. And listen, we all know money does weird things to people, right? I mean, somebody dies, people turn evil, right? Like it just does. And so understanding what's real is important. Now, I will say that there's lots and lots of people, if not most, of the people that exaggerate some have very real things going on. Very real. You need to figure all that out. And somebody could tell you, Doc, it's really hard for me to focus. My wife keeps having to really, tell me things over and over. Okay. Well, we need data to support what that means. How impaired are they? What kind of change have they experienced? The physician that I was with a couple of days ago, we had a great conversation. He was cracking jokes, really good back and forth, right? But when I tested him, his memory was in the bottom 10% compared to other physicians. Average compared to a normal person, fine in conversation, but I'm really concerned about him continuing to practice. And that's something I'm going to have to address, right? I had a case where someone had very high level deficits, meaning if there's lots of stress, if there's lots of things going on, if there's lots of chaos, they really struggle to multitask and process. So I got a call last week. I said, Jeremy, we have a problem. Okay, what's that? Myself and the defense, we just did this deposition with this guy, and man, they were great. They were organized, their thoughts were good. I'm not understanding. You said they have thinking problems, and we both sat there, hour-long deposition. They were spot on. Like, is your data wrong? What's going on? I said, well, tell me about the deposition. Okay, it was in a quiet room. Okay. And we asked questions and they responded. Okay. Was there any distractions? No, we eliminate distractions. How long did it last? An hour, hour and a half. Okay. So can you help us understand? Sure. They're fine in controlled settings. They're good for an hour, hour and a half. They're not good for 3 hours. They're not good for 4 hours, right? And the deficits that they have are really high level. So they're going to notice problems when they go back to work. When they now have to manage based on their job, 3, 4, 5 things at once, they're going to have problems. And that is why you did not notice it in your controlled setting. And thankfully, they're good enough that they can hold a conversation. I'm glad you were able to get that. And the response I got was, this is fantastic. Thank you so much. It now makes sense to me. I can understand what's going on. Again, it looks at neuro and psych. All neuropsych evaluations have very detailed treatment and can help establish prognosis, and it directly lends itself to the life care plan. I have data that can support this is exactly what they need. Now, again, I'm not an MD, so I'm not going to write about their chiropractic care. I'll leave that to you guys. I'm not going to write about, they need to meet with whatever, their pain doctor. Like that is outside my area of expertise. But I will say this is what they need from the neurologist. This is what they need from psychiatrists. This is what they need from psychology, from neurorehab speech therapy, from neuropsychology. We'll outline those for the period of their life, right? Their life. And in all things neuro, we can do that, right? We can pull all these things together and help you manage your cases this way. So what happens when you add a neuropsychologist to your case? It gives you the tools to help a judge, a jury, understand the severity of symptoms. Great example. I was sitting in a jury trial probably now, I don't know, 6 weeks ago. The days blend together lately. I'm sure they do for you as well. But I was sitting in there and we were talking about attention problems and memory in particular. And the argument was made to me, and they said, Dr. Hertza, we want to understand. You said in your deposition that memory was fine, that was a strength. You said that. I can show the jury. I have video here. Do you want me to show the jury? Want me to show them? I'll show that you said 3 days ago in your deposition memory is fine, and now you're saying, oh no, it's impaired. So I turned to the jury and I said, ladies and gentlemen, so I don't know any of you, and I don't know your lives, and I don't know your families, but I want to tell you a little bit about mine. So I have a 14-year-old son, almost 15, right? Super smart kid. He's gifted. He's very social. He's a good kid, right? And he has ADHD. Well, so does half the plan. So does the dad, right? So when he's in school last year, what happened? Well, he forgot about a third of his assignments. He was super disorganized. His room was a friggin' giant mess. And guess what? He doesn't have brain damage. His memory's fine. Did he forget things? Absolutely. Why? Because his thoughts aren't well organized and he struggles to sustain attention. So I turned to the jury and I said, I don't know if any of you have a kid that has ADHD, or if you have ADHD, your kid, yourself, you don't have brain damage, but your memory certainly varies, doesn't it? And I got smiles and nods from the jury. And now instantly, everyone understands this is what's happening. This is why it's like this. And it turns symptoms into impairments. That's important. It's one thing to have a list of these are the problems. It's another thing to really explain in detail how it impacts day-to-day functioning, how it impacts occupational ability to sustain gainful employment, and how it impacts the future. And it creates the story. It creates the meaning. This isn't just data, right? This is the story of what happened. And for me, when I'm in front of a jury, when I create that story and I help explain it in things that really make sense to people, all of a sudden everyone gets it. And then it gets really hard to defend against because it makes sense. One thing I do often, and I mentioned this earlier, is I screen cases. And, sometimes they need a full workup. Other times they don't. But I'll go through the records, I'll provide an opinion, I'll give you some guidance. So any of you have interest in that, I'm certainly willing to help you understand this is a case I should hang my hat on. This is a case I should not get sucked down this rabbit hole. And I promise I will absolutely tell you that there are cases you shouldn't go near with the 10-foot pole. So, question, right? So, okay, I get that testing thinking and emotions is important. You can screen my clients, no problem, fully evaluating them, guide treatment. Why do I need a neuropsychologist to do it? Lots of providers say they do testing. I've run into physical therapists that do some type of cognitive screening, chiropractors that do some cognitive screening. I've run into this. But neuropsychologists are the only providers trained in neurology, psychology, tests and measures with board certifications to back up this knowledge. They're the only ones that can look at the data and say, this is due to sleep, this is due to brain injury, this is stroke. I got a case a couple of days ago. Somebody must really think I'm good because this case is a mess. And this is someone, the child has autism, was abused, sexually abused when they were young, went in the foster care system, now is with a grandmother, has been thrown out of like 3 or 4 schools, was actually hospitalized for trying to kill his sister, jumped out of a moving car. So you can see this is a problem, right? Now he gets in a terrible car accident. And I have to explain what's due to brain injury and what's due to all this other giant mess, right? But I can do that. I can tease that apart. There aren't other professions that can do that. It's one thing to look at the data and say they have problems with attention, blah, blah, blah. It's another thing to say with absolute confidence, this is what's causing it. These are how all these things fit together. And they're defensible. So I want to talk about the testing. I want to talk about what the reports look like and what these processes are. So again, we talked about earlier, there's different parts of this, right? The first is your clinical evaluation. And you generally do an interview with the patient and then a collateral, right? Anytime you can, having a family member that helps support the things that provide you insight. Usually I go after a spouse because if any of you are married, you know your spouse is super happy to tell anyone all the things that are wrong with you. And that certainly happens in my world. So you can look at some somatization disorder, and that's where psychological distress leads to physical symptoms. Is there psychosis, mood issues, TBI? I do dementia work every single day. Everything from Parkinson plus diseases to is this Alzheimer's versus CTE versus vascular dementia, to tease all that apart, right? The second piece is the neurobehavioral examination. And that's sometimes cranial nerve testing, gait, balance, muscle tone thinking. But that means that we are watching them, interacting with them, and making sure that what they say, what the record says, what we see, and what the test data shows are all integrated into one concrete opinion. The testing itself is standardized procedures, and those are designed to examine the integrity of brain functions and structures. It's important, right? This is not a Facebook quiz. The tests are selected because they actually line up through imaging with specific parts of the brain. And that is why all tests are not equal. And as a layman, as a lawyer, even as a chiropractor, you have no training, or maybe you do, but most don't, have training and to understand what tests actually correlate with certain areas of the brain and which one test to function. Super important. Just because the test measures attention doesn't mean that there's not other parts of the brain involved in that particular test. So then you have no clue what you're measuring. You might get data that says they can't focus, but you don't know if it's a processing issue. You don't know if it's white matter tracts that are leading into the frontal lobe. You don't know if that's focally frontal because that test wasn't correlated through neuroanatomy with a particular part of the brain. So we are truly measuring and doing a functional brain map of how all these different things work together. And we're pointing out strengths and weaknesses related to pathology and potential. So we get a referral, we do a good intake. Um, Please, if you use me or any other one, please send us records, right? I got in an argument with the lawyer about a year ago who said, well, I'm not going to send you records that don't line up with my case. And I said, well, I'm not your guy because I'm going to get destroyed. I'll get killed in deposition and there's no way I'm going with you to trial. He said, well, I was taught that you should only really provide, you shouldn't offer things that somebody may not have seen that's contrary to your case. And again, then I'm not your guy because that means on that stroke case I mentioned earlier that I wouldn't have got the stroke records. That means on the case I'm doing now with this autistic kid who tried to kill his sister, I would have no clue he was autistic. That's a setup. I can't help you. And I need to make sense of what's real. I'm not for sale. I'm not. I'm going to tell you what's actually happening. And I'm going to make sense of the data that supports your case and the data that doesn't and how it all fits together. And frankly, it works out just like it did in the stroke case. Now, all of a sudden, the argument that why is it that one person's affected and no one's not is the whole point of the case. The stroke actually is an asset to the case instead of being muddy information, right? That muddies it up. So we do an intake, get records. I do recommend that you get 3 to 5 medical records prior to injury so you can establish a neuro baseline. And I don't often get that. And I'm telling you, it makes a huge difference when saying the accident caused this, right? That could be from a primary care doctor where their mental status exams are unremarkable. Doesn't matter, but that data is important. We do the neurobehavioral status exam, which we talked about is that hands-on engaging. We are able to do neuropsych testing fully telehealth, but is the exact same tests that are done face-to-face, just done through telehealth. So this is not, we're using totally computerized systems. That absolutely does not happen because then you miss out. A, the tests aren't normed on parts of the brain, they're normed on function. And then B is you're missing out on all the behavioral stuff that provides true meat to what you're seeing. There's scores and there's context, and they both have to be taken together. The tests have to be given a very specific way. It's all manualized. Nobody's winging it. And the scoring is also manualized. So everything has to be done a certain way. Otherwise, you can't use the statistics to match it up. All neuropsychology is math, all of it. We take the data and we're using advanced statistics to understand what's going on, right? This is a science that's based on data. And then everything is integrated together. There's a report that goes out and there's feedback where we give results. My preference is usually to tell my patients, what's going on. And one of the things I tell every single person I meet is, I'm here to help you in your case. And I have 2 roles. The first of which is to really make sure your treatment's spot on. I run treatment plans all over. I own another company where we manage major hospitals and we have fully integrated medical and neuro care. I manage them across the state of Florida, also in Georgia, right? And so it's a matter of being able to really develop the appropriate treatment plan, and that involves all the disciplines together. So those reports will come with a very solid treatment plan, and it could flow from me downward, okay? But again, the second thing I tell people is, 1, I'm here to help your care be completely spot on. And 2, I'm here to help other lawyers, a judge, sometimes even a jury, really understand how this has affected you, right? For real, how it's affected you. I'm here to give you your voice in explaining these things. And the third thing I tell them is, when this is done, when your case is done, when the lawyers are gone, and you're sitting there at home and you're wondering, what in the world do I do with my life? I'll still be here for you. Sometimes I could treat you personally. Sometimes I'll set you up with someone else, but I will not walk away from you. I will not leave you hanging because I care. And I want their life to be good. I want the best outcome for them. I want the best outcome for the lawyer because obviously I believe in the things that are going on, but the patients come first. So we look at what is the purpose of the assessment, to look at, is this psychiatric, neurological, what's going on, really guide patient care and really help with quantification of symptoms. Puts a number on it. Now, just supporting the things I'm saying, the American Academy of Neurology endorses neuropsychology in the treatment of stroke, Parkinson's, traumatic brain injury, multiple sclerosis, epilepsy, neurotoxic exposure. I've recently become involved doing mass tort cases for toxic exposure, right? And that's how I was involved in the Flint water crisis. We assessed 75 kids, 75 over a week, and we were determining if their issues that appear kind of autistic, and particularly their dyslexic symptoms, were tied to toxic medical exposure or they were just dyslexic. And if I found them positive, they got immediate check. It was like 300 grand. And so really, and for me, I was hired by the judge and by the court, not by a specific lawyer. But I think there were 700 kids and we did, like I said, roughly 100. So we can evaluate and identify different things that are going on. You'll get somebody that's 75 that's in an accident and the average age of Alzheimer's is 70, and somebody's got to figure this out. Is this brain injury or is this a dementia? And what is the relationship between concussion and dementia? I make calls all the time as to whether or not people are safer driving, if there are functional risks related to them working or managing day to day. I make decisions every single day on whether someone can make their own decisions. And I do that actually in the hospitals. Somebody is refusing medical care and I need to make a capacity decision. And that stands up in court every single time. I can predict functional outcomes, monitor recovery after TBI, and there are guidelines that really recommend kind of what needs to happen. Now, the intake, that's information that we get on the beginning. And again, please send all records. We then determine the tests that are given. And again, neurologic and psychiatric conditions have very specific patterns of dysfunction. The observations, testing is just a snapshot, right? We really need to look at what's happening and take everything in context. To show you some of the areas that we look at during the neurobehavioral status exam: motor, sensory, perceptual, memory, processing, executive functions, language, and emotion. And briefly here, and I'm trying to watch my time for everyone, briefly here, we'll show you actually what tests correlate with that. And the testing is done either by the doctor themselves or a psychometrist. They're a master's level provider with training in just this. They work directly under the doctor. And the neurobehavioral status is a combination of what the doctor sees and what those technicians sees. Teletesting, particularly what we do, which is the same test scaled to telehealth, is 100% valid. I've done hundreds and hundreds of these cases and never run into an issue. But not all testing is the same. So you need to trust in what's given. And particularly since COVID, there's a lot of new things that exploded, right? It is truly the Wild West since COVID. And frankly, a lot of it doesn't hold up, because even if it does a good job of testing a function, it doesn't tell you what's going on in the brain, right? It's like an IQ test versus a neuro test. So tests are standardized to age, education, ethnicity, and so on. And often there's verbal instructions and everything has very specific guidelines. Here are some of the domains we look at: reasoning, executive function, motor, personality, memory, adaptive functioning, ability to manage ADLs. You'll see here effort and malingering, right? So the research supports that effort and malingering should be looked at a minimum of 3 times during an assessment. I gave a lecture yesterday for a very large physical therapy group. I think I had about 75 people in the lecture. And one of the messages I got is, Dr. Hertz, as a physical therapist, how do I test for malingering? And again, the research supports you don't just add 1 test, you need a minimum of 3 in order to have any type of confidence. For me, people fake different things. Some people fake memory loss, some people fake emotional distress, some people fake attention problems, sometimes effort varies. So like all that has to be cleaned up. You need to be confident with what you're stating. So that is also assessed in detail. And we're really the only specialty that does it at that level. Here's an example of some tests that look at memory, achievement, and you can refer to this at a different time, but I do want you to see some of the really good tests that are well studied, that do a really good job to help you differentiate what's maybe something new that isn't as good versus something that's truly legit. So all this does test the brain. The frontal lobe looks at attention, executive function, working memory, self-control. The temporal lobes look at language and memory, parietal, visual perception, occipital, vision, visual integration, white matter is processing speed. I was telling them yesterday in that lecture that a couple of years ago, I gave a full comprehensive neuroanatomy lecture series. It was 34 hours long. Somebody started laughing and asked me if I did it all at once. Absolutely not. There'd be way too much alcohol involved. It was spread up over a couple months, but in detail, how all these things work together. And here are some examples of the tests and the divisions of the tests that are actually looking at the different things. You'll see attention, executive function, language, and so on. So going back to the computerized test, totally cool with them. They are screenings. They're only screenings. They do not replace a comprehensive assessment. Now, I'm completely fine during a neurotrax, a cryo, CNS impact to screen your patients to find out is there anything wrong. But then the next step is if anything is wrong, then you need a full assessment to know what in the world is going on here. With validity, this kind of highlights that you need 3 or more tests. The potential for fabrication or exaggeration is higher in forensic context, also higher in workers' comp. It is what it is, right? We need to own, just like data that may not line up with your case, you need to own it. You need to understand it, not just avoid it. And by the way, I did not work with the lawyer that decided he wanted to not provide me all the information. With validity, we look at consistency, the performance on testing, the performance on psychological testing, because people fake different things. And PVTs, performance validity testing, should garner more weight than subjective indicators, meaning just because you think they gave good effort, if they failed those validity tests, trust the validity tests, right? Because people are really good at lying, they're really good at exaggerating, and there's some really talented malingerers out there. Going back to what I said earlier, is there's tons and tons and tons of people that have very real, very legitimate thinking problems and psychological deficits that exaggerate, right? It's just the truth. There's money involved. Like I said, it does weird things to people. And we have to tease all that apart. So this isn't they're faking nothing's valid, it's understanding what's real and what's going on. And sometimes that's subconscious or unconscious. Often we see a cry for help. People have been struggling for months, for years. No one's listened to them. No one, the title of this is Understanding and Seeing the Invisible, right? So often this stuff's forgotten. A question I'm asked often is, okay, the person had a concussion. They didn't complain of thinking problems for a month. Then they did. Explain that, Dr. Hertza. Sure, they were focused on all their pain, all the things that were going on. The brain was bruised, called a penumbra. The penumbra shrunk. Their pain got, managed, and all of a sudden they realized they have these problems. That's it. That's why, right? It can be explained when it makes sense. The test is scored compared to self-report. It's compared to the medical records. It's compared to the people themselves. And the statistics come to us, scaled scores, standard scores, T-scores. And then ultimately, all that's put into a report that pulls things together. Factors that we tease apart are medications, mood, motivation, quality of sleep. Is there other pathology? Pretty rare that somebody's perfect, right? And then they have other things that are going on, right? So, and we can understand the impact of all of these things. So, where do I find someone that can do this? How do I get somebody to help me screen my cases to look at these things? Here's our contact information. This is where you get to reach out to us and we get to help you. We're happy to help you in any way we can. Even if it's behind the scenes saying, hey, Dr. Hertz, what do you think of this? I ran into this. This thing's funky. Or if it's, I'm trying to build my case and really capture all the ways that my client is impacted. Can you help me with this? So I'm going to go ahead and unshare my screen here and then go up. So the neurochemical cascade after brain injury takes 10 days, okay? So that is where the brain depolarizes, repolarizes. There's changes to cerebral blood flow and ions, and that takes about 10 days. So, but frankly, after an injury, by the time everything gets settled, usually it's about a week or two later. So I would generally say, you're waiting a week, wait 10 days, let that neurochemistry kind of stabilize. At that time, it's time to bring us on. Now, the brain recovers for up to 2 years after TBI. So if we get somebody early, it's about saying, yes, there's something real and really guiding the treatment. If somebody's 2, 3 years out, certainly there's some treatment that's warranted, but it's far more likely to be like a true IME to understand and create a life care plan and things like that. So, if you're not sure, send us and we'll let you know. We want to wait a week, or why didn't you give it to us 3 months ago?
How about the neuropsych evaluation, though? That does require a period of time where you can kind of get as much medical information as possible. When are you finding that to be ideal in the case?
Again, so like on the clinical side, and I do return to play for lots of sports. I was the sports neuropsychologist for two Big Ten schools. So when I get like a concussion, like a sideline concussion, I'm doing an evaluation to determine what's going on acutely. We're coming up with the plan for that, 7 to 10 days. I do an assessment, which then guides treatment, and then we work through it. So truly, again, the answer is exactly the same, right? Give me
Okay.
a week, 10 days, and let me go in there, because it's not just about assessing at the tail end. Truly for a living, I write treatment plans and guide people through rehab.
Thanks for watching this video. Your brain doesn't have a reset button, but it does have a roadmap, all things neuro and Neuro 360 for the data-driven truth about TBI and neuro wellness. No fluff, just the science you need to stay ahead. Hit subscribe. Knowledge is your best defense. And visit our website, neuro360care.com and allthingsneuro.com.